And we're just going to go back a little bit. So you all know what Krabbe disease is. This is the latest categorization forms as infantile, late infantile, juvenile, and adult onset Krabbe disease. When newborn screening started, the idea was there's an early infantile Krabbe disease variant, and then there are later onset forms. It wasn't very well delineated what the differences are. Also, the idea was that the early infantile Krabbe disease cases are the most common, and so newborn screening will identify those that need immediate treatment. And the idea was that they all have the 30 kb lesion in the homozygous state. So anyway, we learned a lot, and thanks to many in the room and maybe online, and, including Dr. Escolar, of course, the categorization was refined, and so that's how we ended up at this point with these 4 variants, where infantile Krabbe disease presents in the first 12 months of life, and without early initiation of treatment, these patients don't survive more than 2 years. And then late infantile Krabbe disease cases presents within 12 to 36 months of life, and is also fatal unless these patients get treatment. And then you have these milder but still very serious later onset cases, juvenile and adult onset. The treatment options at the point when you have developed symptoms and are diagnosed because of that is basically symptomatic care, palliative care. But if you find them early enough, you can do a bone marrow transplant or hematopoietic stem cell transplant, where Dr. Kurtzberg and Dr. Escolar almost 20 years ago published this very important paper that showed that early initiation of the transplant can lead to significant improvement in life outcome and quality of life. And so there is a treatment, but you need to do this treatment very early on for the infantile cases. And now currently we have 1 gene therapy trial from Forge Biologics that is ongoing. And I hope we hear some update on that, where you do IV gene therapy after the patient had already received a transplant. There was another trial that was started and then was ended, not because presumably it didn't work, but because the company had a new CEO. They looked at the books and decided Krabbe disease is too expensive, and so they stopped it. And then we know of other companies that are interested in picking that up or taking a different approach to gene therapy, and hopefully they will come to light, especially if the current trial was not as successful as we would want it to be. So again, there is a treatment, but you have to identify these patients early, and without a positive family history where you can kind of anticipate that the baby may have Krabbe disease, without newborn screening, you will not identify these patients early enough. So we do need newborn screening to give these families a choice whether they want to pursue a transplant or not. So, and as we all know, it started here in New York with the Hunter's Hope Foundation that convinced those in power that newborn screening for Krabbe disease was important. And so in 2006, it started. Shortly thereafter, also there was the attempt made to bring Krabbe disease to the RUSP, which had just been established at the time. And in 2009, then the advisory committee voted after an evidence review against addition of Krabbe disease to the RUSP. So that was 2009. The reasons given that they felt that there is not enough information about what early infantile Krabbe disease actually is, how you screen for it, how you diagnose it, how good is the treatment, how do you what's the benefit of it all? So they had a lot of, I think, valid questions. And so many of those came because they looked at the newborn screening program and wondered if it was really going as good as it could be. And I think it went as well as it could be with the information that we had when newborn screening started in New York, where the test that was done was based on the GALC activity measurement by tandem mass spectrometry, an assay that was developed by Mike Gelb, who sits back there. Joe Orsini, who is also back there, modified that assay a little bit to make it work for New York. And then they also knew that there is an overlap between GALC activities in patients with Krabbe disease and individuals that are carriers or carry variants that cause reduced enzyme activity but not disease, which Dr. Wenger is not here, called pseudodeficiency. So that is a cause of false positives. So to mitigate that problem, they decided we do an additional test as a second-tier test or reflex test when there is low GALC activity and do molecular genetic testing. And the expectation was, well, we will find, of course, variants that are disease-causing, and so we can make a diagnosis and reduce false positives. Well, after 8 years, they checked how they were doing and published this. And there were 2 papers, and this is the one that talks about the clinical outcomes. And they were very clear that the New York experience raises some questions about the risk, benefits, and practicality of screening of newborns for Krabbe disease. So kind of indicating that, yeah, we identify cases, but it doesn't work as well as we would like it to, because we do have false positive results, and that is a problem. Now, again, why do we have these false positives? So the enzyme that's defective in Krabbe disease, galactocerebrosidase, was first identified in 1970, and that allowed us to establish an enzyme assay. And then in 1993, Dr. Wenger found the GALC gene that codes the galactocerebrosidase and described it. And if you look currently in ClinVar, an online database of variants, you will find that there are more than 1,500 variants listed. Of those, 247 are known to be pathogenic, so they cause disease, and 131 are benign. So that's about 378 variants where we know what they actually would do. And then you have another bunch that are likely pathogenic, of uncertain significance, likely benign, or with conflicting interpretations. And that is 75% of all the variants that we know. So you can imagine, if you do molecular, you may find a pathogenic variant and you know what it means, but most of the time it will probably linked with another variant that is not of known significance. So you develop what I consider a genotype of uncertain significance. So nevertheless, newborn screening continued from New York, and currently there are 12 states screening for Krabbe disease. The latest was Minnesota, that started in February. A month later, we identified the first case, and Dr. Orchard can tell us about that one. So currently, that's about a third of the US population that is already being screened for Krabbe disease. And then Iowa is probably the next state that will screen. And that means that there's actually 3 more states, Alaska, North and South Dakota, that will also be screened because they sent their blood spots to Iowa. So that will increase the number of babies screened, even if you screen 4 states, by only 61,000 babies. So we've been involved at the Mayo with newborn screening for Krabbe disease, first through a research study, which actually brought me to this meeting many years ago. And then because Kentucky added Krabbe to their screening program and wasn't quite prepared to do it in-house, and so they reached out to us and asked whether we could help them. And so we did that. And this is how we do the screening at the Mayo Clinic for Kentucky. We have now an 11-plex assay. That means we measure 7 lysosomal enzyme activities and 4 lysophosphatidylcholines for adrenoleukodystrophy. And then we have a bioinformatics tool that looks at all these data and looks at whether the baby looks like any other healthy baby or looks like maybe be affected with Krabbe, Pompe, MPS 1, 2, or adrenoleukodystrophy. And when any of those conditions may be a possibility, then we do a second-tier test. So we don't contact the family, but we take another punch from the blood spot and do a more specific assay. And for Krabbe disease, we measure cycosine. And cycosine was unknown to me until I was here at a meeting about 11 or 12 years ago, and Dr. Orsini was presenting data on measurement of cycosine in blood spots of babies with Krabbe disease and showed that cycosine was elevated in those babies. And at that time, we did that study that I mentioned earlier. And I asked Joe, can we send you some blood spots? And he said no. Not because he's a bad guy, he's not, but because he didn't have the assay in his lab anymore. And so he couldn't do it, but he said, but I help you if you want to bring it up. And so I said, let's do that. And so we worked together, including also then Mike Gelb and others, and brought up the first version of the assay to use it as a second-tier test. So working a little more and also improving the assay further, we then figured, well, maybe we have a way how screening for Krabbe disease should occur, where you first measure GALC activity, and then you measure cycosine if it's necessary. And if cycosine is elevated, then you call it out as positive. And when cycosine is normal, then you're done. The screen goes out as negative. With that, you don't have genotypes of uncertain significance. And we determined that the newborn screening laboratory's responsibility is to do these measurements, the GALC activity and the cycosine, and then report it accordingly. So with that in mind, and also advances in the treatment by improving the transplant regimens, and then gene therapy at the horizon, the Hunter Soap Foundation, and some of us thought, well, now might be a good time to bring it back to the RUSP. And so in July of 2021, a letter went out to the committee that suggested we have a way to screen for Krabbe disease. We know that these patients are doing well or fairly well when you find them early. We don't have false positives, so we think it should get on the RUSP. And so they did another evidence review, and in February of 2023, they came together, they looked at the data, they voted, there was a tie vote. So the same number of people were for as against, and so the chair decided, well, that of course means it's not going on the RUSP. So we were angry, just a little bit. We sent a lot of letters to the secretary complaining, but also with a lot of arguments, I think, that were valid, because what we heard at the meeting was really annoying, and some of you have heard it, so I don't have to repeat all of that. It takes us too long. But anyway, eventually we got a letter back from the committee that listed these things that they felt were still not where there was not enough evidence regarding the effectiveness of the treatment, and also making the correct diagnosis. There were assertions that babies might get transplanted that don't have Krabbe disease. So a lot of questions that we thought had been answered already. So, but one of the things that I was wondering about is, well, we told everyone how to screen for Krabbe disease, and there are states that use cycosine. What's the problem? So 12 states are currently screening for Krabbe disease. 8 of those use cycosine as part of their newborn screen for Krabbe disease. And so we surveyed these 8 states and asked them, how is it going? How many did you find? What cycosine cutoff do you use? And also because at the advisory committee, there was a suggestion made that maybe you raise the cutoff for cycosine so that you have only infantile Krabbe disease cases. We wanted to know what would happen if you apply a different cutoff to the cycosine to make a determination if the screen is positive or negative. So 7 of the 8 states responded. And what we found is that there are 4 states, including Minnesota and South Carolina, that had been screening for less than a year. Actually, Minnesota hadn't screened when we started the survey, that really rely on cycosine to say the screen is positive or negative. And then there are states like Illinois, New York, Indiana, and Pennsylvania that still use sequencing in parallel to cycosine. And then even when cycosine is normal, report low GALC activity when there is at least one likely pathogenic variant present. And Missouri and Tennessee use cycosine, but also have or had a fail-safe cutoff for GALC. So if GALC is very, very low, they report it without waiting for the cycosine to come back. And New Jersey and Ohio at this point don't have a second-tier test at all. And this is important, again, because we don't want to expose too many families that don't have Krabbe disease to be have to go through the follow-up and even to think about the idea that their baby may have Krabbe disease. I think that is not what newborn screening of a whole population is about. We really want to identify the kids that have the disease and bring them to treatment as fast as possible. So also Dr. Thompson Stone and others developed a consensus recommendation, which is a guideline as to what do you do with the kids when they have an abnormal newborn screen, which helped to simplify a little bit the initial protocol that was developed in New York. And here are the results of the survey. So you can see the states on the top, and you can see that can you see my cursor? Yes. That the number of cyclozines that are actually necessary are really low, so you don't have to do cyclozine very often. If you look at the cutoffs that are used, you can see there are different cutoffs at different are used in different states. And if you look at Illinois in particular, where they raised their cutoff, you can see that the false positive rate quickly went down when they raised the cutoff for cyclozine. So it certainly makes a difference. And you can see that there are no false positives in those states that rely solely on cyclozine. And the positive predictive value then is also associated with the cyclozine cutoff that is being used and the process that is being used. Again, when you don't rely only on cyclozine, you still have false positives. So then we looked at the different cutoff scenarios. So if you apply a cutoff of 10 nanomolar for cyclozine, then these states would all identify the 11 cases of infantile Krabbe disease. If you apply a cutoff of 5, you find, of course, the infantile cases. You also identify one late infantile Krabbe disease case and 2 late onset cases. And these late onset cases at this point are defined as patients that have elevated cyclozine, low GALC activity, a genotype that is consistent with Krabbe disease, but they don't have yet symptoms in most instances. And if you have a cutoff of 2, you identify all infantile cases, then another late infantile, 2 late infantile cases, and more late infantile Krabbe disease cases. But you don't have false positive results. So 7 states responded. Why is there variable use of cyclozine in the various states? Well, one simple reason that when New York started, there was no cyclozine. And when the next couple of states started, there was no cyclozine either. So they would have to make a change to use it now and rely on it. And that is always difficult to make, to walk things back, but it should be possible. And quite frankly, I always thought when the Krabbe gets on the RUSP with a specific recommendation, that will help the states to make changes as well. So we will see how that goes. Sometimes you have to change just things in your lab system, which is brought up as a problem, or vendor contracts. So all things that I think can be overcome. And as I stated, if you have different cutoffs, depending on where the cutoff is, you can avoid all false positives, and you can also identify only infantile Krabbe disease if that's what you want to do. So with all that complaining and giving more information to the advisory committee, they last year allowed a rapid evidence review to kind of look at the additional data again. And in January of this year, then they came around and made a recommendation to the secretary. Well, they made a recommendation at the meeting that Krabbe disease, infantile Krabbe disease, defined by low GALC activity and cyclozine greater 10 nanomolar, should be included as a core condition in the RUSP. That is what they said at their meeting. And then in July, so a few weeks ago, the secretary finally issued this letter and said that he's adding Krabbe disease as defined with low GALC activity and cyclozine greater 10 to the RUSP. So he doesn't mention anything about a core condition. But if you look at the letter that actually came from the advisory committee to the secretary, there's no mention of a core condition either. And this is consistent with all other conditions that have been added in the past, that the secretary or the committee at that level never discuss core conditions and secondary targets. Examples are multiple sulfate aromatase deficiency, which would be a secondary target when you screen for MPS II, or Zellweger spectrum disorders when you screen for ALD. They're not listed as secondary targets on the RUSP. I don't know why. So what's now? The recommendation or adding Krabbe disease to the RUSP is a recommendation by the secretary to all the states that they should do that. It is not a requirement. So states that already screen can just continue as they are, or they can add cyclozine to their algorithm, or increase the cyclozine cutoff if they want to follow the recommendation. But they can also add cyclozine or change the cutoff in whatever way they want. It is just a recommendation. They can also remove or add molecular testing if they want to. And states that are not yet screening could just not follow the recommendation, not screen for Krabbe disease. They could implement, as stated in the recommendation, for infantile Krabbe disease only. They could implement with cyclozine and choose a cutoff based on evidence that I think we have, that you can use a lower cutoff and have no false positives and benefit the babies that have Krabbe disease. Or you could implement with or without cyclozine, or with or without molecular testing. So it's really up to the states how they want to deal with that recommendation and the addition of Krabbe disease to the RUSP. What the secretary also points out, that screening for Krabbe disease is covered by the Affordable Care Act. Now, there's an election year. I'm German. I can vote here. You guys can do what you want. But there's one party that doesn't like the ACA, just saying. So nevertheless, I think that even if it's covered, states should be conscientious about not creating havoc and always looking at how to reduce healthcare costs that are implied with newborn screening. So false positives means higher spending, maybe not in your screening lab, but downstream, and we should be aware of that. The newborn screening stakeholder community is not done because we now have to help the states to implement screening for Krabbe disease. And I think we should do this continued with focus on performance. So do you want to identify all Krabbe disease cases, or most of them, or infantile Krabbe disease only? If you want all of them, then you will have false positive results. Because we know with a cyclozine of 2, some cases with late onset Krabbe disease have values below that. Those are usually late onset, in my opinion, and if the world tries to continue as it has, all of us will have their genome within the next 10 years. So if a baby is born today with late onset Krabbe disease, juvenile or adult onset, they will have their genome either because it was done on themselves or because it was done on a relative by the time they would have any symptoms. So I'm not concerned about late onset. And then we have to raise awareness about the Krabbe Disease Newborn Screening Council that we will hear about as a means to help the follow-up people to go through difficult cases. And we should share with the states the current evidence and guidelines, as the guideline I mentioned already, but also there are ACMG act sheets, algorithms, and a knowledge nugget that you can find online. These are designed to help the primary care provider who is receiving the abnormal results to figure out what's going on when they get a result that says your patient may have Krabbe disease. And then there are 2 act sheets, one for the infantile form, which is basically an emergency, and for the later onset variants where you have a little bit more time. And there's an algorithm of what test you order next to figure this out as quickly as possible. And Amy Gaviglio created one of these knowledge nuggets that in an 8-minute video tells you everything you need to know about Krabbe disease when you get an abnormal result and need to talk to the family about what the heck is Krabbe disease. Another thing that the secretary did, as he has done for the last several conditions, he asked the committee to give him a report, and in this case, in 5 years, to tell him about the status of implementation, the barriers to timely treatment, about the disease management and monitoring, and about the outcomes. Now, 5 years is a short time frame to give a lot of information about this, but that also means that we need to provide that data because someone has to do it. And the advisory committee will basically ask the evidence review group to look at what has been published. So we need to put stuff out into the literature that kind of talks about how the status of implementation has been going, what are the barriers, how is the treatment going, what are the outcomes, at least for those 5 years. And to do all that, I think we need a registry where these patients are captured in a HIPAA compliant way. This should be a transparent and comprehensive registry, which means it's more work for all the clinicians who have to enter data. But I think it's really important, as it is for all the other conditions on the RUSP. And then those data need to be reviewed regularly to write those papers and compare it then to the cases that are not identified through screening so that we have a control group. So in conclusion, the recommended screening strategy allows for an efficient and effective screening program. And again, the states that screen already for Krabbe disease should review their outcomes and make transparent decisions about weighing the sensitivity and specificity. So again, is it acceptable to have false positive results for such a devastating condition? And states that are interested in adding Krabbe disease or may have to add Krabbe disease because they have legislation in their states where they have to do everything that's on the RUSP, so they cannot look at it as a recommendation, but as a requirement. They also should make informed and transparent decisions about what they're going to do and how they set cutoffs and what their expectations are. And I think that should be on their websites. It should be very clear to everyone that, okay, we're screening per the recommendations. Our cutoff is 10, so don't complain if we miss a late onset case. I think that needs to be very clear. And for now, the laboratory diagnosis of Krabbe relies on GALC deficiency and in leukocytes and elevated cyclosine in red blood cells in the follow-up. And the GALC genotype is going to be always done, but it may not be informative. And but it supports the diagnosis when you find two variants of significance. And with that, I would like to thank everyone in my lab that provides me with all the data, but also the colleagues that participated in that survey paper for sharing their data. And then, of course, Darren and the colleagues in Kentucky who allow us to screen the Kentucky babies, and Mike and Joe, the Rosenau Family Foundation, but of course, most of all, the Hunter's Hope Foundation for organizing this meeting and really allowing us to talk about these issues and figure out what data do we need to collect to move things forward. So thank you very much.